week 5. There is, we're almost halfway through the course, so congratulations. It is not easy, especially this semester for y'all. Most of you have at least 3 courses, and know some of you also have that IV course, which is 4. So I know how busy you all are. Plus, you live lives, you work, you have families. So, this week we're going to be going over chapters 23 and 24, sensory, neurological, and musculoskeletal. Remember, you do have NCLEX questions that are due. I do try to send you little reminders. Discussion question 4 is also there. Yesterday, I did send out reminders just to let you know. You just get them in by Sunday, okay? I know sometimes the Wednesday goes by, you haven't put them in, so I do give you that reminder. Um, one one thing for you to all know is Thanksgiving week, we're supposed to have a quiz, which means you wouldn't be there, right, for the quiz? I have moved it to week 10. So your last quiz will be on week 10, and it will cover week 9's information, okay? That is a change in syllabus so that we don't have to worry about giving a quiz or double quizzes or any of that. So I wanted to let you know that now. So we'll be moving that quiz. Is better for all of you.
So won't be class on that day?
You do not have class on the day after Thanksgiving. No, you do not. It is a holiday, Thanksgiving, that Thursday and the Friday. So it's, quote, a 4-day weekend, which most of you are catching up and then maybe spending some family time together. I'm probably going to have about 50 people at my house this Thanksgiving, combining
That's good.
my
You're
daughter
blessed.
got married, and I'm inviting all of his family over too. So it's going to be a big, nice get together. I'll
Good.
be busy and I love to cook. So let's start with our PowerPoint. Week 5. It is long. There's 107 slides here. So I'm going to go over the stuff that's important, so that you can understand what this stuff is all about. So sensory is all your 5 senses. Neurological is your brain. And musculoskeletal is your muscles and skeletals, and sometimes how the brain affects that also. Ears. We know that young children do have shorter, straighter tubes than adults. This is the reason why you get a lot of ear infections, because it's the back of the throat, mucus goes to the place of least resistance up into the ears. And that's why we have a lot of ear infections then. I mean, eustachian tubes do a lot, but it helps keep everything draining in there. I just had a tube put in my right ear back in August. It was full of fluid. In fact, yesterday I had it checked. Um, Otitis externa. This is me, the swimmer. People, you call it the swimmer's ear. It doesn't mean that when you were swimming, you got it. It just means the outside canal is infected and it hurts. I mean, sometimes it hurts just as much as the internal, the media one, okay? It is a lot of pain. You can pull on it and it does hurt. We treat it just by making sure the ear is open, free of wax, and then we'll put in these liquid antibiotics inside the ear. Rarely do we take anything by mouth, okay? And usually they put like a little steroid in it so it decreases the inflammation and it really helps with that pain. Now, otitis media is the middle of the ear, and it's an infection, has to do with the inner ear gets all inflamed, the tympanic membrane gets swollen, and it can be extremely painful. Little children come in, you get your little 3 and 4-year-olds and you ask them, so which ear hurts? And they'll point to it and you could see their faces that it really does hurt. So we've got those eustachian tubes, again, up there, putting all that infection there. So, how would we know, especially younger children? Will ever see an infant? They'll sit there and they'll hit their head or they'll rub their head on the floor, or sometimes they don't know where to put their hand. They're showing you something. Just like when they put their hand down their throat, their fingers down there, they're telling you their throat hurts. So you will be hearing these things. Now, you also sometimes it's, when they don't respond, the ear is so full. I know when I had that fluid inside this ear, I could barely hear. I would have the volume on my computer on high until I could get into the ENT and him drain it with that tube in there. So it is absolutely valid. You don't hear hearing loss. And then sometimes, because hearing and speech are connected, sometimes they'll have their speech will be not as clear as it normally is. Okay. So these are things that you would see, they're not responding to their names, etc. Now, as I said, it is that tympanic membrane, it's bulging, it hurts. How do we treat it? Well, we need to treat it with an antibiotic. In your throat, in your mouth, normally there's staph. Well, what happens is that mucus pushes it up into the ears, so now you have an infection. So making sure that they take every drop of what they're supposed to take. Sometimes parents like, oh God, I can't give one more dose. My kid don't like medicines, right? And it's like, all right, all right, they've had 6 days, that's enough. Well, make sure you finish it because if we don't take care of your infections, you're going to have maybe hearing loss, and we don't want to do that to these children. Remember, sometimes, like the otitis externa, need to put eardrops in. So you pull it down, pull it back for infants, and up and back for children. And we put the drops in. And then make sure you keep them on the opposite side with that ear pointing down so that we get it in there and that it does, coat, the inner ear. When we have ear infections, and that swelling's there, or we get that fluid build up, surgical intervention is what we do. Now, let me tell you what these kids go through because I had it done in the office, no sedation, no anesthesia. All he did is put some numbing drops down into my ear. And I was scared because this is only the third time. And the physician who did it hurt me the time before. So I let him know, you hurt me and you better make sure that numbing works before you do it again. So he listened, he let it work. But what they do, they put the numbing in, wait. They go in with a scalpel and you hear it go, they cut that tympanic membrane. Then they take a tiny suction catheter, put it inside your ear, and you hear this right in your head. And it doesn't hurt, but it's uncomfortable. And then you feel the tube go into place. Well, that's not the worst. When you get up, that's your equilibrium, right? Your inner ear. I was falling over. I was holding on to the walls, trying to get out of the office. I was very dizzy. That's why we give these children anesthesia, because it's something that they could not tolerate. But I wanted to let you know what it felt like. Now, hearing impairment in children, if it is when they're born, it could be a ear that wasn't formed or a canal or something anatomically isn't correct. This is congenital. They're born with it. Congenital defects, born with it. Then we get hearing loss because that tympanic membrane doesn't allow sound to go through. That is called conductive because it can't conduct into where it needs to go so that we can hear it. Okay. So those two terms you need to understand. Now, how do children talk? How do they express themselves? How do they communicate? Well, we know children of different languages, put them next to each other, they just talk, right? They do expressions, they can hand you things. It gets into the lip reading, sign language, etc. Those are for permanent hearing loss, right? And they can express what they need. Children are great. They're so resilient. Teach them how to talk, using expressions, and they work really well. Now, as a nurse, When you are talking to a child that has hearing impairment, it's very important. Number one, get down on their level. Number one, we know that any kid, you don't want to tower above them. They're going to feel that you're threatening them. And then, of course, it's face to face. All right. Eye level, face to face. Make sure that child is looking at you, looking into your face so that they can at least see your lips moving. You are going to talk in very short sentences. You can't go blah da 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 la 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 la. They are not going to understand. Short sentences and talk normally. Don't try to over exaggerate the way that you move, all right? Just very short, okay? And these children do pick up a lot. So, a nurse has been assigned to care for a 2-year-old boy who has been scheduled for a laryngotomy with tube insertion. How should the nurse explain this surgical intervention and its indication to the child's parents? What instructions should the nurse provide the parents before discharge? So, tubes, laryngotomy, we're putting tubes in. Well, I just told you what they go through, right? So, what are some things that you need to teach a parent when they're going home? Because it's a quick outpatient procedure. Literally, it takes 5 minutes of the surgeon's time. It's more time getting the child asleep so that they're not aware of what's happening. What did I tell you about being dizzy? They could get nauseous, they could vomit, right? We need to let them know that there could be some disruption in the way that they're moving, and it shouldn't hurt. Literally, it does not hurt after the surgery tubes put in. During the procedure. Will it feel like a little full afterwards? Slightly, but it's really not horrible at all. Usually, though, what do they do with tubes? They do tonsils, adenoidectomies, and tubes altogether, right? That's when you have the sore throat. Now, eyes. Realize that 4 weeks old, your eyes are beginning to develop. Now, when babies are born, they do not see clearly. They have one eye working and the other eye working, and they do not work together. And what that means is they have no depth perception at all, okay? So it's called binocularity is the word for it. But about 9 months old, those eyes realize, oh, I got to work together so that I can see clearly. Because can you imagine seeing here and they're not working together? Their eyes are less spherical and usually they don't cry until at least 1 month or more. You see a newborn crying, it's very unusual. And the one thing I really upsets me, little infant, 3 to 6 months old crying, and you see the tears, you're like, that child really hurts. Well, there's different names for eye problems. Myopia, nearsighted, means I can't see far, right? Which is why do they do that? I don't understand. Nearsightedness is far, and farsightedness, I can't see near. It's backwards of what you think. So, myopia and hyperopia, 2 words you need to know. Visual impairment. So, it's the eyes going in the wrong place, muscles aren't working as well as they can. So, there's three that we talk about: strabismus, amblyopia, and nystagmus. Well, strabismus is where they're trying to focus and the eyes don't totally work together. Okay. Usually, one eye works better than the other. Again, they use patching of the eyes, strengthening those muscles, usually strabismus. Amblyopia. This is that what we call that lazy eye. You have one eye that sort of goes crooked, inwards, outwards, up and down, and the other eye is straight. Well, it's lazy. What's lazy about it? The muscles are weak. So, how do you strengthen a muscle? You exercise, right? How do you exercise the bad eye? Cover the good eye and let that lazy amblyopia eye work. Let those muscles get strengthened. And they take the patch off and on several times a day, okay? And then we have nystagmus. It's sort of a jerky. You'll see the eyes just twitch, not necessarily together, but you'll see it backwards, ups, and sometimes you see them around. And that's jerkiness, okay? So the cross-eyed, they can't focus. Amblyopia, one eye is crooked, moving around. And nystagmus, it's just jerky. So let's look at, again, the treatments. We also, put the patches. That's always one of the ones we use. And just think about it is the patch covers the muscle that works. It leaves the muscle on the eye that doesn't work and it makes it work. And through time, it improves. Sometimes we have to put glasses and sometimes they're given exercises. Put your eye, look up, down, sideways, or it could be showing shapes and stuff. They're all different, but it's using the eyes as an exercise. Rarely, but sometimes it's needed. Severe amblyopia might need surgery to strengthen the eye muscle. Conjunctivitis. I mean, you've all heard of conjunctivitis, pink eye. This is a goopy, caked up in the morning, you can't see, yellow, green, beige liquid in your eye, and your eye is itchy, swollen, and reddened. And children spread it a lot. I mean, as I say, put a kid in daycare, put the kid in school, and all they're doing is exchanging each other's toys and pencils and whatnot, and they're exchanging, as I call it, swapping spit all day long. And with that, it's on their hands and they get it in their eyes. Extremely contagious. It's a staph infection again. So what do we do? Well, once we see the goopiness on it, we just clean from the inside out. Just a warm washcloth, just keep the exudate, keep it clear. Put in some ophthalmic ointments or drops. Remember, ointments will make the sight cloudy. Warn the kid. Now, I'm putting in some goopy stuff in there, but remember, you're going to be a little cloudy, your vision. And once it warms up, it's going to have your vision back again because they just think they can't see. They'll be scared. They'll be very scared. Even adults be worried about it. Very rarely do we put these children on oral antibiotics. It's usually just the liquids or the ointments there. I tell, and this is just between, you as parents and you as future pediatric nurses, I tell the parents to change the child's pillowcase every day, right? If you don't, what happens? They're just reinfecting. And I don't want them to clear up the infection and they turn the pillowcase back over again onto the site that was dirty and they get the infection again. So I always tell them, change pillowcase. And that's not in any textbook. That's just me. Retinoblastoma. Do you see those little white shiny eyes? It looks like animals out in your backyard and there's a light on and you see like a deer, you see a cat, a dog, and you see those shiny eyes. Well, this is what a child with retinoblastoma is. And it's something that will alert you. Usually it's one eye, rarely it's both eyes. I have not seen both eyes, only on one eye. And it is cancerous. And with that, they have to take the eye out usually. They'll do laser and chemo, that beam right into the eye. Many times they put that little purple mark on the eye where they need to zap it at. Remember, never ever remove any radiation blue marks until after they're done with it, okay? Because they measure really carefully and put those lines there so that they get it in the same place all the time. And then they'll take an eye out, usually. And I saw this in high school. I had one kid who used to take his eyeball out and roll it around on the desk just to gross us girls out. Well, I guess that was a retinoblastoma looking back at it. And then he put it in his mouth, lube it up, and stick it back in his eye. I'm like, oh my goodness. And I'll remember it. I know what it is now. I didn't then. The nervous system, the body is this being where the brain controls everything, right? It does everything. You breathe, your heart beats, you move. All of these things are from your brain, right? We know that we can have these congenital malformations, or it can get infected, or it can get a brain injury, right? A concussion. So the cranial nerves, you've learned them in your health assessment. Here they are again. You're going to ask, do you need to know them all by heart for this course? No. You just need to know that there are cranial nerves, okay? That's probably a relief for a lot of you. Here are they all again. Looking at it and what they do, it is a great slide to go back and look at. What causes an altered level state of consciousness, or your LOC? Well, there's many different things that can cause it. The one thing I always think about is lack of oxygen, right? If you don't have oxygen, you're going to have an altered state of consciousness. Now, what if your blood pressure is not where it should be? Low blood pressure is another cause. It's not getting blood with oxygen to the brain. That makes sense, doesn't it? Another thing is fever, because oxygen is burnt up with a fever. We know there are drugs, sedatives and anti-epileptics that also tend to dull your brain, and it could cause a altered state of consciousness. Seizures, of course, and then anything that increases pressure in there, swelling, whatever center in your brain, it could be dulled and you're not going to be as alert. Now, one of the things that, as an emergency room nurse, the last 10 years of my career, I worked at a excuse me, very busy pediatric emergency room. I was one of their primary trauma nurses, and we'd get kids falling in off of second floor story balconies and many different things. And the first thing we always check on these children, coming in by rescue, helicoptered in, is their pupils. If you have pupils that look good, they're dilating, and they're reacting, we're doing good. Now, if all of a sudden you see one get big, dilated, and not moving, there's increased pressure in that brain. This is telling you this child is bleeding, this adult is bleeding in the brain and needs emergency attention. It's swelling, it needs that pressure relieved. So a fixed dilated pupil, absolute neurological emergency. We should never, ever, 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 ever give our children aspirin for whatever reason, except one condition. And that's your Kawasaki. It's in the cardiac section, and we'll be doing that next week, okay? Aspirin can cause something called Reye syndrome. It's rare, but it can happen. And it's something that if they get Reye syndrome, it's an extremely difficult syndrome for these children to come back from. So we recommend Tylenol up to the age of 6 months. And then from 6 months on, your Tylenol and your ibuprofen, right? Acetaminophen, ibuprofen from there on. Aspirin, absolutely not. In fact, if all you have is aspirin, no, you're not going to give it. Let the kid be with a fever. Take his clothes off, have him something cool to drink, right? It's better, it's safer. Meningitis. This is another definition. You need to know what this means. Meningitis is an inflammation of the meninges. Itis, meninge, right? Inflammation of the meninges. And it goes from the brain and it goes down the spinal cord. And meningitis, we'll see viral, and there's bacteria. I mean, we think all meningitis is antibiotics and admitted to the hospital. And no, not really. Viral meningitis, we're just going to treat with acetaminophen, ibuprofen, and liquids and rest. Okay? It's the bacterial one that needs the antibiotics. Now, signs and symptoms, headaches, absolutely. Fevers that stuff neck, photosensitivity. And then depending on the amount of swelling, you could have that altered state of consciousness, right? Sleepiness, or really can't get up and moving. This obstinatinosis is a heck of a word to say. Remember, that means that neck stiffness, okay? And that's when you have those arched backs, and then you'll see the stiffness in the neck. One of the things about infants, up to the age of almost 15 months, they still have a fontanelle here, a little soft spot opening. In meningitis, you will see it swelling, bulging. It should be flat with the head. I love a young child because assessing, you could really easy look at, do they have meningitis? And you could look at fluid, right? Are they dehydrated? It'll be sunken in. Or we could see it too much and we could see it bulge. So fontanelles are big things with infants. And one of the things with children in any condition, especially when their brains, quote, hurt, they are going to be irritable and children will not eat. They have a fever, they're not going to eat. And, meningitis, you'll see that also. There is something called Brudinsky sign and Koenig sign, and both of these are looking at if there is meningitis, okay? That will look for the neck stiffness there. And those are things the physician will do. We could do them too. So, meningitis, be prepared. You suspect meningitis. You don't know if it's the viral or bacterial, absolutely, until you do a spinal tap. Spinal tap comes in and you're a bacterial meningitis and you're going to be admitted. They will be placed on antibiotics. After 24 hours, they're going to be safer. The first 24 hours, they need to be in a reverse flow room, which means none of the air goes back out into the environment. It's filtered outside. And you as a nurse have to wear those N95 masks to protect yourself from meningitis. After 24 hours, you're pretty safe. I mean, I still wear a mask, but you are safe at that point, according to the literature. Meningitis has an inflammation of the meninges, the brain. You're going to be doing neurochecks, pupils and strength, right? They can follow directions. And if we can't see that they are, something's going on. Anything with the brain, you always worry about fluid, always. Intake, output, daily weights is the other thing you'll be watching. And these children, they're so sensitive, their brains, that you're going to have a quiet environment. I actually like very quiet music going on, especially the younger kids. It's calming. And you don't have the flashing of the TV screen going on, just a little music. And actually, it helps. Types of seizures. Well, I'm sure you all heard of a febrile seizure. And you're going to say febrile seizures are dangerous and febrile seizures are, we need to medicate them with acetaminophen and ibuprofen. And once you see the fever, yes. But what do you see? Somewhere between 6 months and 5 to 6 years, depending on the literature. What happens in febrile seizure is you have a child in normal temperature. And all of a sudden, less than 30 minutes later, it's 102. The rate of rise, or how quick it went from no temperature to a temperature, sparks something in the brain on these children, and they have a seizure. It can happen once, or it can happen multiple times. My first grandson had it, and only once did he have a febrile seizure. Many parents are going to ask you, so does this mean that my child is an epileptic? And the answer is no. In order to be considered epilepsy, you have to have about 1 to 2 seizures per day unprovoked, which means no fevers in there, okay? And there are children who get epilepsy. A lot of children with cerebral palsy can have also epilepsy, right? And there's different types of seizure. We've heard of grand mal, which is also tonic-clonic, and that's when you have the generalized arms and hands, loss of consciousness, foaming at the mouth. And then you have partial, and it could be just a blank stare. It could be you're talking to them and you're asking them, hello, and they're not there. It could be just like that. Or it could be, just one shoulder going or one foot is twitching. It's not the whole generalized. So, how do we teach parents to take care of their children if they have seizures? Well, If they have fevers, we try to medicate as soon as possible. I think my sister-in-law became a fanatic. She carried two thermometers, Tylenol and Motrin in her um, purse, and she never went anywhere without them. And she would take these kids' temperatures 10 times a day, I swear. So the kid never had a chance to have a fever. It was 99.9, and she's giving Tylenol because she wasn't going to go through that again. And I don't blame her because it is scary. But other things that can cause seizures, of course, you have ear infections, you have pneumonias, you've got cellulitis. All these things could cause fevers. We know epilepsy is part of seizures, right? It's part of the brain not working right, and I call it like sparks that occur in the brain, and it creates the response of the body movement in things ways it shouldn't. We know some drugs can cause seizures, and then low blood sugar in children, especially your newborn, your younger children, it can cause it. So all of that things can cause seizures. What can spark some of them? Well, that flashing of lights, especially in epilepsy, moving them quickly. I told you fluid balance is important with children with anything with seizures. Overhydration causes pressure building up in the brain, and then the brain just starts sparking to try to respond to it. And of course, that photosensitivity, which is part of flashing lights. So, how do we treat it? Well, we need to find out why it's going on. Is it febrile or is it a brain tumor, right? Or is it just an area in the brain that is very hypersensitive that sparks the brain to go into seizures? Now, see the little kid there on the top, these things posted on, what they're trying to do is figure out where in the brain is causing that child to have seizures. Do you know sometimes they'll do a whole removal of half of a brain? Have you ever heard of that? They take out half the brain. These kids do well, believe it or not, and they stop the seizures. At Nicholas Children's in Miami, we have great neurosurgeons, and I've seen it done. And I'm still like, you removed that much of the brain, and this child is awake and alert and is eating breakfast. I'm like, okay, just to let you know that can happen. We're going to look at, just to make sure there's no tumors or anything like that. CAT scans, MRIs, the EEG, like you're seeing right there. And then let's look at electrolytes. Some electrolytes can cause seizures, magnesiums, calciums, those things can cause it. And at that point, when you determine this child definitely has seizures, quote, epilepsy of some sort, medication's going to be used. And some parents decide to go and change their diet. They remove all the carbohydrates. They do all different things, gluten-free things. And I've heard them work really well. It's just very difficult to have your child on those diets for any reason, but many of them do well with it. So you're a nurse and you see a child and they have seizures and they are on your area that you're taking care of. Well, just to be safe, because you don't know when a seizure is coming, do you? There's not like, okay, at 1 p.m. I'm going to have a seizure. No, it's not that way. You walk in and they're having it. So always, those side rails must be up. And you will see in a hospital setting, they will take like blankets and pad those side rails so that they don't bang them as they're having seizures, right? If they're in the room, a lot of kids are up and moving around. Older kids are. You can't just keep them in bed. So make sure that if there's anything sharp, anything that they could run into or hit when they're having a seizure, make sure it's padded. Always have them with a medical ID bracelet. It's not like adults would carry a phone and we could put medical alert epilepsy, right? Children, some sort of necklace, bracelet, something, that denotes it so that as if they're not with you, they're in daycare or something, and it got a new daycare person working, they go, oh, this kid's having a seizure. Oh, yes, they have a history of it. And then they could find out, oh, what am I supposed to give the kid? Always avoid the triggers for sure. And one of the things, again, is making sure they take their medications, take it on time, follow up with a physician. Many of these do have drug levels that they must be following. So, a 3-year-old is a new patient with a diagnosis of seizure disorder. What possible types of seizure might the child be experiencing, and how are they characterized? What aspects of the boy's seizure activity should the nurse observe and document? And what instructions regarding the seizure should the nurse provide? Well, we've just gone over all of that, didn't we? So, what type of seizures are they? Anybody, give me 3 types. What are some types of seizures? What did I just mention?
Generalized seizure,
Generalized seizure,
Yeah.
tonic-clonic,
partial
febrile,
seizure,
febrile,
gamma,
and partial.
Focal, partial.
Very good. So remember, seizures are not just one thing. It could be a little bit of anything. Remember, as nurses, when you see a seizure occur, check your clock so you know what time it is, as quickly as you're protecting the child, right? But to know where are the seizure occurring, what does it affect, so that we can document. Sometimes getting the understanding of how it progressed can help with the treatment. Now, how do you tell the parents to take care of a kid with a seizure? Well, it is said, turn them on their side, right? Many of them vomit, especially tonic-clonic, those generalized. Turn them on their side and make sure that you're protecting their area, that it's free from sharp objects so they don't hurt themselves, right? You cannot stick anything in their mouth. It's not going to work. And just be there supporting them. It's very scary for parents. Now, cerebral palsy, many times it could be due to a congenital thing, or it could be due to hypoxemia at birth. I've seen it occur that way where they couldn't come out the birth canal and they were stuck and they had to run and do C-sections and get the child out that way. But there's been some hypoxic episode, and some of them had from very mild to very severe cerebral palsy. We know cerebral palsy is brain. Palsy means sort of a dullness. That means they're going to be having some intellectual and developmental disabilities. Cognitively, they're not going to be exactly where they should be. In children, how would you suspect it? Well, what do infants do? They suck, swallow, and breathe. If they don't feed right, they can't suck, swallow, and breathe. That's cognition. That might be your first thing that you look at, okay? We also know if they're having seizures and they have no fever, of course, that's going to cerebral palsy. And then, of course, they are not doing the milestones in their development the way that, a child without cerebral palsy would do. One of the things that comes to mind is taking a 7-month-old child, holding their hands and they're on their back, pulling them up and their head lags back. They should have complete head control by then. Usually a child with, moderate cerebral palsy won't lift their head up. Their head falls back. And that's just part of, the beginning of that diagnosis. Now, I was doing clinicals for Fortis down here in Miami, and one of my boys, cerebral palsy. It was a nonverbal cerebral palsy, little Jonathan, and he had really spastic cerebral palsy. This child would see me, his smile goes ear to ear, and he put his hands up because he wants to hug me. And that's the spasticity. They actually started botulism injections on this child, and his spasticity has decreased. Another thing they did is put him on an anti-Parkinson drug. Parkinson is the shakes, right? Have you covered that in med-surg yet? It's like a shake and a shuffling gait. It's levodopa carbidopa. It's that medication. He got it, and it has helped him stop with the shaking. So both of them can be used really well. Remember, good skincare because they're moving different. They're, checking, make sure that they're not having any skin breakdown anywhere. Because that spasticity and the feet trying to go down, like foot drop, whatnot, braces are important because we try to keep as much function as possible. And sometimes, if they're very tight, these things, they'll do surgery to release those tendons which are causing tightness. Now, the word athetosis is all about involuntary movements that they can't control. It's another dictionary word you need to know. So how do we take care? My little Jonathan, how do we take care of him? He's now 7. He was like 6, 5 years old the last time I saw him. Well, we need to have him the ability to move around. Now, he was nonverbal, but this child was smart. He had a little pad that he could talk on, very simply, but he could communicate. So that communication is great. He was in a wheelchair. And as he gets older, they're going to give him an electric one to move by himself. And that's your locomotion. Making sure his motors function is great. He was getting physical therapy, occupational therapy, speech therapy. When I was a teenager, I used to work for the Cerebral Palsy Foundation as a volunteer. And when you went to these places, inpatient care, um, or even the ones that came for the whole day, they would take the kids out of bed, put them in a wheelchair, feed them, put the TV on, right? Then go back, change them, put them back to bed for a nap. They didn't work on their minds. Well, Jonathan knows his colors and he knows his shapes, and that's through that little pad. So now we are trying to get them as smart as they can be, because once you really get to that level, we can get them even further. And it's not just nurses, it's like everybody, multidisciplinary, including parents. So, intellectually impaired children have the same psychosocial needs as all the other children, but they can't express it or respond as other children do. Jonathan was in a room with a bunch of children his same age, and they'd put on these everybody clap your hands and songs, and he would not sing, but you would try to do the movements and put them involved. And it's what he needs, and he needed to be around other children. And his smile told me everything. So, how can you be successful when you have a child with intellectual impairment? Well, number one, there are children can do certain things and other kids can't. Now, we are going to praise what they do well, but we will not accept bad behaviors, even if they're intellectually challenged and impaired. Just because they are intellectually disabled, there's no reason why they should be able to hit other children or throw toys at other kids. And these sort of things that you will see. So always praise the good things and never accept bad behaviors. So, as nurses, how are we going to take care of these children? And I love this saying here, every person deserves the chance to reach his or her full potential. I mean, I haven't seen Jonathan in 2 years. I need to go back to see him. It's not too far away from me, and I know that the place would let me in with open arms. They've tried to hire me for years, but I'd like to see how he is and what he's doing and what he's learning. So, every care plan for these children are individual. They're all different. They're all unique. That's what kids are. They're all different. So make sure that we have a plan that they can succeed in. Give them that, praise that they do need, and, make sure that they're not doing those bad behaviors. And in the hospital, as nurses, we need to continue the same, knowing that these children, most of them today, are in some sort of plan of care where they're getting the physical, occupational, and speech therapies, in order to communicate and to be the best that they can be. Try to continue that in the hospital. So, disabled children, again, emphasize the strength. keep those parents involved with it. So make sure that the parents know what's happening. And, don't use labels. These children are all special, unique, and wonderful. Many of them are the most loving kids that you'll ever meet. Okay. School nurses, a lot of these children are placed in normal classrooms. I've had children that unable to speak. Does not mean that they are less than. It just means that they needed something to speak for them, and they've got those little computer pads and stuff to help them with it. A lot of these children that have special needs, intellectually, are not cognitively as aware. Remember, a lot of them look absolutely normal, as in whatever normal means. Okay. It's not going to have the appearance, let's say, of a Down's child. They look normally. Just remember that some children, um, doesn't mean what they look like, doesn't really mean where their level of cognitive awareness is. So you have a 6-year-old boy who's developed cerebral palsy from a near drowning 16 months ago. His parents would like to know what should they expect of the child regarding his education and future, and why would a near drowning cause CP, and what should the nurse tell the parents about realistic goals? Well, why was a near drowning almost cause cerebral palsy? Why? Somebody tell me that answer. Why
The
did I tell you?
oxygen.
Yes, the oxygen, absolutely. It was a hypoxic episode. The water filled the lungs. They didn't get oxygen. Yes, and that's what caused it. We know we don't know how far a child will come back, but we know if we do the therapies as soon as we can, we're going to get a lot of it caught up. It may not be perfect, but we can at least have a child be able to communicate and to be able to do more than we ever thought, as long as we work with them closely. Head injuries. Well, head injuries increase intracranial pressure, an hypoxic moment, it's swelling, and cerebral edema, an infection. All of these things can cause, problems with blood flow to the brain, and again, can cause those cognitive delays, right? We know that blood doesn't get there, the intracranial pressure is too high. We know that the brains or part of it can die, and those areas, once it's dead, it's dead. You can't bring it back. And is it on speech? Is it for hearing? Is it for movement? Is it for just understanding? So a lot of these things you have to. Every child will act differently to a head injury. We know a concussion that has amnesia. That means that they forget what's going on and they get confused, can be more serious than a fractured skull and you didn't see anything. Okay? Fractured skull doesn't mean that you'll have the head injury. Just a simple, sports injury where they have amnesia could be worse than that fractured skull. Shaken baby syndrome. I've seen this. I've seen a 3-month-old with shaken baby syndrome. Actually, it was twins with shaken baby syndrome. And they were shaken and they were actually smashed in the shower against the wall too. So it was like a little bit of both things. And it can, and I don't know in the end, the outcome. All I know is the twins both had fractured skulls and fractured femur, fractured ribs, and we know that the concern is always the brain. This child had behind the ear. I picked the kid up behind the head, and it seemed like my thumb went almost right into the skull. I'm just very carefully picking up that child, this kid, and he cried. So I knew it hurt. Again, checking those pupils. We don't know about if they're drowsy, blurred vision when they're that young. He was not vomiting, and he was breathing okay. So O2 sats are okay. but we know that children with shaken baby syndrome can be completely unconscious and cause, irreversible damage. Decorticate and decerebrate. Decorticate is to the cord, right? Decerebrate is, extending. And you will see these type of posturing in children. How do you know if you have a child with increased intracranial pressure? Well, many of the cases that I've seen where you're concerned was a child sliding into third base, hit the knee of the defender, and you heard a big crack, and the child came into the ER and was like, "So was I safe? Where am I? Is daddy coming? Was I safe? Where am I? Is daddy coming?" And it was just repeated, repeated. And that was the level of consciousness, okay? Pupils are okay. Remember, low blood pressures can cause more problems in there. And, also we're going to see how is the child moving. So these are things that you'd look for. How do you monitor children with neurologically? I mean, if you look at the top of this child's head, that's a bolt. It's a bolt that's screwed right into the brain. And you know what that does? It measures intracranial pressure. Something happened with that kid that they needed to monitor it closely, and they have a bolt in. It doesn't hurt, obviously, the kid's smiling, but that's what they do when you have children with intracranial pressure that's high and they want to monitor it closely because we can do things to lower it if we have a number there. It's like getting a blood pressure. Same thing, it's a number we can work with. We know pain response. If a kid is unconscious and you can touch them, shake them, they wake up, okay. There are times where what we do is a nipple twist. Can you imagine twisting both nipples and they're not moving? We know that child neurologically is really far gone. And it's something I've seen the physicians do repeatedly on all different ages of children. The cranial nerves, are they working, sticking their tongue out, all of those things? Are they moving properly? Of course, the posturing, are the cerebrate, the corticate, pupils, absolutely you're going to look for. And in infants, that fontanelle, it's always something you look at. How about scalp vein distension? That's showing swelling going on there. Ataxia, which means spasticity of the lower extremities, meaning they're stiff and they're like even the feet will point down. Morotonic neck with withdrawal reflexes, you're picking them up and are they going through these? Now, I live in South Florida, so I've seen a few drownings in my life. And it is the fourth leading cause of death in children under 19. And as we said earlier, why does this create a big problem? It's the hypoxemia, which can do that cerebral palsy. Their brains don't come back from it. We also know we could just have aspirated, and sometimes actually the hypothermia helps, right? It prevents it from being as worse, but it is that aspiration hypoxemia, and it can cause, lifelong disabilities. One of the things about near drownings, they say if it's over 10 minutes and they don't gain consciousness, they usually were not going to make it. Now, another thing with drowning, just because they drowned, came up, you pat them on the back and they spit the water out and they start breathing, get up and start running around, does not mean that there's no injury. Believe it or not, 72 hours these children must be watched. It could be a delayed response to the hypoxic episode. These children are always admitted to at least a step down unit monitoring their oxygen saturations. So a 7-month-old is brought to the baby girl is brought to the ER by her mother's boyfriend who was babysitting her. The baby is in an irritable state. The nurse overhears the physician say that he suspects shaken baby syndrome. What might cause the physician to state the suspicion? And what signs should the nurse look for which may indicate the infant has suffered a head injury? Well, we just went over it, and me talking about these little 3-month-old little baby boys, the one who came in, and then we called the other one in when we realized what was going on. It is that physical sign, and it's also the child be inappropriate, and it could be just the crying and consolability and all of those things. Pupils could be different. The one who that incident that I'm talking about was abuse, and the mother brought the baby in, and it was the husband who actually hurt his children. So it could be the hardest part about being a nurse at this time is not trying to beat up who has that kid, right? Like, why are you hurting a child? Well, I, you know, bit my tongue, and then we found out it was the father, and yeah, the father's in jail now. So muscular skeletal conditions. Well, that's club foot, that top left one, and there is a child who is getting around, and those are pretty neat walkers that they use. The little boy who's the bodybuilder, his father made him into the bodybuilder at a young age. I've seen a lot of programs, documentaries on that little guy. And that's that picture on the top right. So we know muscles and bones work together, right? So the muscles make the bones, and that's why you walk. We know that skeletal growth is between 4 to 8 week, and we know it supports the body and it lets you move, and it makes you move forward, and you can run and walk. Hyperemia is what we call an increased blood flow to different tissues in the body. It's just a definition there. Picture of them. We know epiphyseal plates are growth plates. That's how children grow. Their bones get bigger. There's a plate there. Remember, if we ever crack that, we have to be careful, making sure that it's not crooked, because that's where the bones grow. So if it's crooked, it could mean a crooked arm, crooked finger, crooked leg, could be crooked anything. So we have to be very careful with epiphyseal plate fractures. How do we look at muscles and bones, and how do we assess them? Well, let them walk. That's the first thing. You have children come in, mom says, something's wrong with the right leg. And I'm like, okay, put them down, let me see them walk. And well, they either don't put their foot on the ground, or they limp, or they don't want to walk and they just touch the toes. And that's going to tell you a lot right there. Then you're going to touch it. Is there swelling? Do you feel anything? Your range of motion, does it move or is it painful? Always neurovascular checks, capillary refill. And then if we have children who are not walking by 18 months, there's something wrong. My children, my grandson, they always talk about my little Christian. He never walked at 12 months. Yeah, he stood up trying to take a step. The kid never walked. He ran at 15 months. And you know something? My daughter and my son were the same. They never did. Now, if they didn't walk by themselves by 18 months, there's a problem. And that would have needed some investigation. We know toddlers, they walk and they like waddle, right? To the side. Their arms don't swing, believe it or not. Look at the little toddlers. Their arms don't swing like we do when we walk, right? By 18 months, we should have a more narrow. By 4-year-old, we should be able to hop on a foot. And now our arms are moving with us. And now we're starting to run real fast, right? And by 6 years old, they're just like an adult. They're not clumsy and walking well. So when we do observations and we're looking at muscles and all the neurovascular signs, we're just looking about, is everything doing it the way they should? Is the right side and the left side all looking the same? We know as neurological, we're going to do looking at those reflexes, making sure, touching that little kneecap and does it move? I can't tell you how many kids have taken the hammer and banged my knee before they banged their own knee, and they just think it's the neatest thing. And we just sit there and giggle about it. And it could be very threatening, but I make it more fun. How do we test? Well, bone scans, CAT scans, x-rays, MRIs, ultrasounds, all of that stuff can show us, is it, the bone looked the way that it should? Is it a solid? Is there a tumor in there? Is there a fracture? What's going on? Now, we also do other sort of tests when we're looking at muscle bone. A CBC, an elevated white count, could show some problems actually in the muscles. It's an inflammation, they're working too much. A sedimentation rate looks at inflammation. And then this HLA has to do with rheumatoid. Now, rheumatoid arthritis is muscle bone. It's actually the body attacking its own joints, and the joints are affected by muscle and bone, right? So these are all inflamed. So you'll see the elevated white count, you'll see an elevated sedimentation rate, and you'll see an elevated HLA. And this is just part of rheumatoid arthritis. And even with those, sometimes I have RA, very difficult to diagnose. So how do we treat problems with the muscles and the bones? Well, sometimes arthroscopies, we do those a lot on your knees, right? Especially older adolescents with sports injury. We need to go in there and look at the joint, what's going on, see what's happening. Sometimes we need to do a biopsy. We have osteosarcomas, and those are femoral bones, a lot of them. We can use traction, and traction is used to help straighten the bone and stop the spasming of the muscles around it. We use that, for instance, in femur fractures. And then, of course, if the kid has a broken whatever, we're going to put a cast or a splint on it and it immobilizes it. And what's great about children, they get colored casts. I mean, you could put the green and the red cast on for Christmas. You could put orange and black on for Halloween, and we could make it less threatening. In adults, you get a white one, and you're lucky you get that. How do you have a problem? Soft tissue, sprains, strains, How do you treat it? Well, the first of all, you need to rest it. That means don't walk on it. Put ice on it because it rips the tissues, tendons, and it causes swelling. Put ice on it and it causes vasoconstriction. So it helps not having so much swelling. Then you're going to compress it, an ACE bandage, to prevent it again from swelling, and you put it up. So if it's swelling, it's going to go back and it's not going to be as bad. I have many times in my through high school playing volleyball come down and on my ankle, and you hear it, and I'm like, oh, I'm in trouble. And I put my foot right up in the air because I knew immediately that's what I had to do. How do you prevent these sort of things? Well, if we have these sort of things going on, it's immediate rice, rest, ice, contain, and elevate it. That helps the best. Warming up, sometimes using ankle braces, etc. That really can help, with all of these things. Always on exams. I don't care if you're HESI, NCLEX, normal exams, injury prevention, safety prevention, infection control, always something that you do see. Now, car seats. We've talked about it. We want it front facing. We want restraints, and it's in the middle of the back seat until 2 years old. And at 2, we can turn it front facing. Okay? Bicycle helmets need to be worn. And then if they're in any sport, soccer, they need those knee shins, and they need, all the proper things to protect them in their sports. A pool fence is now almost mandated by house insurance, or your insurance is going to be really a lot of money. window bars, depending, deadbolt locks, get the kids so they don't go outside. One of my when my daughter was 3 years old, she decided to have a closeout sale in her bedroom. She took the screen off the window, and they had those. This is a long time ago. They had those windows that you screwed open, and then she took her clothes, which was right next to her dresser, and threw them out the front window. So she had a closeout sale. So we had to take a nail and we just, put all of those windows she couldn't get into, because it is real. She could have gone out there. And actually, my son went out the window and and next door they had these Rottweilers that were mean, and he was trying to go up to them. And my his father heard something going on outside, ran out just as he went to go to that dog next door. So making sure windows are secure, whether they're bars or whatever, or deadbolts. And cabinets, your kitchen cabinets, making sure that the things that they can get into can't hurt them. Now you have all types of fractures. Okay, so here's a listing of them, and we're going to go through them. So we have green stick, which is one side is bent and the other one's broken. Okay, so it's one bone bent and the other one's cracked. Compound is when the bone comes out of the skin, and that one needs antibiotics because now you're in danger of infection. Simple fractures are probably the most common of all the fractures. The bone is broken. Sometimes it's displaced, sometimes not, but it's intact. The skin is intact. And they put a cast on it and they do well with it. So simple are the most common. Oblique is when it's angled. It's literally a break that's angled. And then spiral fracture is an indication of child abuse. It is turned. It's like you take the kid and you pull them and you twist their arm wherever, and you could tell that is child abuse. So what do you see with a kid with a fracture? Well, it's going to be swollen. It's going to be tender. You might see bruising, discoloration, and limited motion. Children with leg fractures will not walk on it, period. They will not put any pressure on it. Children, though, the pretty neat thing is the younger the child is, the quicker these bones heal. If you have an infant, let's say for whatever reason they have a fracture, I mean, it could be less than a month, 2 to 3 weeks, that fracture heals. As we get older, it's 4 weeks. And then when you get to us, it could be 3, 4 months before it heals. Same fracture. Children heal so quickly, which is pretty good because you don't want them in cast a really long time, right? Because they get into things like jumping into swimming pools with a cast on. I've seen that quite a bit. So how do you take care of a child in traction? Well, why would you put traction on a child? Well, right here on the bottom, you see this child here. It's called Bryant's traction. And many times they use that for hip dysplasia. Okay. Now, there's also traction which pulls, straight. Bed, slightly elevated head of the bed. And then you have the feet are not on the end, they're out. And let's say you fractured your femur. That bone muscle wants to go angled, and those little sharp edges really hurt. So it pulls it so it's straight. Okay, so you would have Buck's traction. And now, how do you take care of those different types of things? Well, number one, you always check neurovascular signs. There's a break, there could be swelling, and circulation could be impeded. That rope needs to be free and the weight needs to be there, swinging freely, and it's for 24 hours a day. You don't take it off. So you always chart neurovascular signs, that the weights are free hanging, and how much weight have you put on there. If there is the area where they can pull and move themselves, there's an overhead trapeze. If not, you as nurses need to pull them up. So Bryant's traction, as I said, it can be used for femur, but many times it actually is used for your hip dysplasia. If you look at it, these children should be less than 15 to 18 kilograms, okay? It can't be more than that. It's not going to work. And you notice the butts are slightly up and it's pulling that leg straight and it's pulling the hips out. So it's giving them good positions. As I said, that buck's traction, there it is, it's pulling. Again, the most important thing to check in any child in traction, there's a broken something or something's not lined up right. You always worry about blood flow. So always do neurovascular signs, looking at the color, and always documenting that. Russell traction is like Buck's traction, but it has that little extra underneath the knee. Why would you use one or the other? It's a physician's decision. Or maybe the child can't keep it straight in Buck's, so we put Russell's that's more comfortable for them. Whatever it is, they both work. Now, that was skin traction, Bryant's and Russell's. And your Bucks. Now, this is skeletal. If you notice, there's a pin in that knee there. They used to just use Steinman pins to correct a femoral, your femur that was busted. Today, we don't use this as much because we're going to be doing surgery. They put a rod down the femur now to straighten it up. And we only use this traction until we can get them to surgery. So when you talk about skeletal, skeletal is with metal or a pin, and a skin is just you attach something to the outside and it pulls. Nothing enters. Now, sometimes you have these external devices for many reasons. A lot of times it was a horrible fracture. It's the only way to hold it. Remember, these are pins going into the bones, holding them the way they should. Your biggest concern is going to be infection, right? So meticulous skin care and pin care, okay? Very, very important. What are you going to look for? Well, we're going to rule out for signs of osteomyelitis, fever, redness, swelling, and if it's getting more and more painful. So let's go over what we need to know about traction, whether it is pins that's going in or if it's just skins. Keep the body in alignment. The head of the bed shouldn't be up too high because then it's not pulling correctly. The heels of the feet have to be off the bed in Bucks or Bryant's. That we do exercises on the other areas, right? We need to be worried about clot prevention. So AE hose, right? Neurovascular signs, checking the skin integrity, not only of the pins, but where that traction's pulling, it could be creating some skin problems. Pain medicine should be given as needed. And if we're giving pain medicine, they're on bed rest in these traction devices, make sure you prevent constipation because that's the biggest thing there. And if they're older, those good trapezes, they can change themselves. If not, you are. Again, weights are hanging freely. Don't let the kid get to it. All right. They bed linens are not traction ropes. You'll see all a bunch of crazy things that go on, and make sure that the body does not go and touch the end of the bed because you're not getting the full pull of the weights that you need. Always neurovascular signs. I can't say that more than once. It's the third time I've said it. So look for their peripheral pulses. Are they there? The dorsalis pedis, the posterior tibial. Is the capillary refill good? Is the color good? Is it warm? Can they move it? All of these things need to be documented. And it's the 5 P's that you have to be concerned. So a nurse is on the jogging trail, and suddenly a 10-year-old boy swerves his bicycle around her, loses control of the bike, and falls 8 feet in front of her. Initially, he denies sustaining injury, but the nurse noticed that he limps slightly when he goes to retrieve his bicycle. How should the nurse handle this situation? What do you think could be going on? He's limping a little bit. Well, number one, isn't it rest? Sit down. Let me quick look. It could be something minor, or it could be up to a fractured femur, fractured hip, could be anything. So, number one, have him calm down, have him sit, and just touch the areas and see if there's any swelling with capillary refill. You could save a child, from undue pain and stress by figuring it out. Cast and splint can be made of mostly anything. Um, we know that the biggest thing when we're doing cast and splint is always skin integrity. Many times these injuries are so severe, there's huge swelling that goes on. So sometimes it gets swelled so far that the cast, the splint compresses circulation, and you could cause the loss of a leg, a toe, a finger, an arm. So compartment syndrome, it is a progressive loss of the perfusion because the swelling, and you're going to see that because of neurovascular signs. You're going to check it. If there's still pain, still moving, not an increase of pain, you're doing good. Kids in a cast, remember they need to keep them dry. I told you, I don't know how many kids I've seen get the cast on, go home, put on their bathing suit, and jump in the pool. And the mother goes, "You didn't really just do that." So now they're back getting a new cast. They should be about 72 hours, keeping it dry, have it up on a pillow, teach them how to touch their finger, their toes, making sure neurovascular signs good, and keep it elevated. And if they see signs of compartmental syndrome, increased pain and swelling, they need to get to the doctor quick. Now, osteomyelitis is a bone infection. It could be due to that bone that stuck out in a break, or it could be, I see a lot of stepping on something with your feet, and then your big toe gets swollen. I've seen a lot of big toes, believe it or not. And it is dangerous, and you can lose, the toe, the foot, the whatever. So, number one, you got this big, swollen, red, uh, big toe. What are we going to do? Well, you visualize, you see it, it's painful, it's red, it's swollen. Neurovascular signs are decreased, okay? And then you're going to do a CBC. Well, infection, you're going to be seeing elevated white count, right? Any infection. And osteomyelitis is an infection. So we'll be seeing that. We're going to do an x-ray. Sometimes you can see it, but bone scans are actually good if where you are has that ability to do that. The treatment is several weeks of IV antibiotics. And remember, we got to be careful with IV antibiotics and making sure they're monitoring their urine output, right? Some of these, like vancomycin, can cause problems with hearing and kidney damage. So making sure that they're drinking plenty of fluids and watching their urine output and following their blood levels. Again, always, if they're in bed with this, making sure that they're doing exercises to prevent any blood clots, and also making sure that they're medicated for pain. And in children that have to be more mobile, they immobilized, that they can't get up and move around, give them something for diversion. I mean, give the kid an iPad, right? They'll be playing Roblox forever. I mean, sure, but remember, diversion does help at this. Now, muscular dystrophy. Muscular dystrophy is a progressive degeneration of the muscles. The most tested and the one that we see the most is Duchenne's or Becker's muscular dystrophy. Duchenne is males, ages 2 to 6. So these kids by 2 years old are up and they're walking, right? They're moving. And then all of a sudden, you start to see their calves are going to get big. They get atrophied or hypertrophy. They get bigger. They start to get tired. They start, when they're walking, they're clumsy, they're falling down. And now what other muscles? You start to see developmental delays, problem with learning, breathing. It is progressive. Now, one of the things that this picture is the perfect of everything that happens. And what do you need to know? Well, it's progressive type of muscular dystrophy means the muscles stop working. They they fall a lot, they're clumsy, they are on the floor, and they're now looking like me, like the old lady getting off the floor, where you take your hands and you walk up your legs to get up. That's called Gower sign. And because of decrease in activity, a lot of these kids are a little overweight. It gets worse, it continues, and usually in their adolescence, they die from cardiac failure or respiratory because you have a phrenic nerve, which is a muscle diaphragm, right? And then, of course, you have your heart. It's a muscle, progressive degeneration of muscles. A slipped femoral capital epiphysis is also called coxavera. And what happens is all of a sudden the hip twists off. And all of a sudden their thigh hurts and they can't put weight on it. So it's right at the hip joint and it separates and it's painful. So think about that Buck's traction again. It pulls it and it keeps it in alignment. Leg calf perf, another one. The difference in this one is an aseptic lack of blood to the ball of the hip, basically. And it is in boys 5 to 12, and it takes time for this one to heal. There's no blood going there. They don't know why. Usually through time, taking NSAIDs for pain, and sometimes at the acute stages, they might put them in that Buck's traction, but it is painful. Many of them end up having osteoarthritis in the hips later on in life. So it's a painless limp. You can't move your leg the way you should, and you're going to find it through those x-rays and bone scans. And, as it goes on, and that osteo, as I said, you might have to get that hip joint replaced, and that's usually a little bit later. I mentioned earlier osteosarcoma, right? And this basically is cancer of the bone. The bone, the long bone, the femur is the one that's a lot of them. And there is all of a sudden, it's going to get painful. And it gets more and more painful as it grows there. These are that 10 to 15-year-old. And what happens is they have to take the whole bone out for treatment. That upper right picture is the lower leg taken off the femur bone, take the lower leg, turn it around and putting it back up into the hip. And why do they do that? It's the place to put a prosthesis. So now they're going to have the ability to be mobile. So it's a bone cancer. They have to do a radical surgery, but we try to save that lower limb to use it. Ewing sarcoma is sometimes you're going to see it in the scapula, sometimes in the jaw. I mean, it could be anywhere. And the goal here is we need to remove the cancer. And all of these cancers are all dependent on have they metastasized yet for their outcomes. Juvenile idiopathic arthritis. Now, JIA or JRA, I mean, rheumatoid arthritis, idiopathic arthritis is the same thing. A lot of times we'll see this in children, ages about 1 to 3. And as I said, the body attacks the joints, okay? And it is extremely difficult to diagnose. I mean, I'm a nurse. I was only diagnosed finally, maybe 8 years ago. And I've been suffering for this for, another 8 years before that. And nobody could figure out what was going on. So finally they said, oh, let's do this new test. And they found it. Like my numbers were off the chart, as the doctor said to me. I'm like, well, you're not listening to me. I told you what it was. But what would you see in children? All of a sudden you're going to see that ankle on that left foot swelling, red, they hurt. Knees are a bad place for it. Elbows, shoulders, toes, ankles. I mean, and it gets swollen and it does hurt. What do you see a lot? Well, you're going to be, and this is so true, so stiff in the morning you can barely move. I mean, try to get up middle of the night to use the bathroom, you have to like sit there for a second and then stand up and stretch up into it. That's how stiff. You'll walk sort of shuffling in the morning, especially. You might limp, and of course, you might see that swelling. And one of the things also is called uveitis, and that's just the redness in the eye. That's why they should go see a doctor. And there's all sorts of what we call JIA. Is it all over? Is it one joint? Is it multi joints? But it's all the same treatment. What we need to do with these children, depending, if it's all over the place, again, or treat them with exercise. I love to swim, stretching. It could be ballet. It could be anything that the kid likes that makes them move. And it is good to do it because it gets the body moving. And then NSAIDs are we given for pain. Now, when we get to this systemic, there's all different things we see. So not only you have these joints that are swelling, you're going to see these rashes and these intermittent fever and abdominal pains. And, it can be, quite devastating and really take control of your life because you really can't move. So what is our goal? So we got these joints that are swollen and hurt. So we want to reduce that pain. As I said, normally it's just NSAIDs, ibuprofen. Promote mobile and preserve joint function. Get up, move. I get in the pool as many days as I can. And when I'm done with a day in pool, it really helps because you're, weightless, right? You don't hurt there. You want these children to be as independent. You want them to be able to be a part of whatever's going on and not make them feel like they're anything different. They just need, to get up, move in the morning and keep themselves moving. And when they sit, watch a movie for 2 hours and get up, they may get up slowly because that's all part of it. There are times where you feel great and there are times when you feel miserable. And, we do give medications for it, and every person, every child are all different. And keeping the kid involved is so important. Let them know that you care and explain what you're doing and why. Torticollis, I've seen this. Actually, my last born grandson had torticollis. His neck, the wry neck, and literally it's a stiff neck. And it's the shortening of the sternocleidomastoid muscle. It's the one in the back here that goes from your shoulder up into your neck. And a lot of times we'll see that because of the type of delivery that they had. How do we know they have it? Well, their head sort of is crooked, right? So how do we take care of it? Well, we don't give medications, but we might put a little warm there. We might do little range of motion, physical therapy, but usually between 2 to 6 months, it's going to be better. Scoliosis. Anybody ever have anybody who has scoliosis? Well, scoliosis is the S-shaped curvature of the spine, and it can be from mild to quite severe, mostly common in girls. And this really, a lot of the times, becomes more pronounced right as they become adolescents, when they're going through that adolescent growth spurt. And they grow 25% of their whole height at that time, and you're going to see it curve more. What do you see with scoliosis? Very important. The hips and shoulders are going to be crooked, and you're going to see one arm longer than the other because you're curved and you're sort of one shoulder will be down. Okay, so that's how you would see it. How do we take care of this? Well, when the spine is curved, sometimes the lung fields can be crunched. So 20 to 40 degrees of curving, we can just put a t-shirt and put a brace on them. And we'll give them exercises, and that can correct it. If it is more than 40%, they're going to do a surgery, and it's called a spinal fusion. And they try to get that spine as straight as they can. You know, sports injuries, I mean, this is common. Kids go out and they get all things. I mean, I've had softballs thrown into my chest. I have slid into home and I've cut my legs up. I have sprained ankles. I mean, think about everything that happens to you, right? And your kids. It's just part of growing up. We know that the sports that you have more injuries are gymnastics, because think about the way you're bending your body, repeatedly. Wrestling, football, soccer, hockey, basketball, volleyball, running, and skiing and snowboarding. I mean, I was on the ski team. I mean, I was in all of these areas that you can really hurt yourself. Now, family violence, it could be a child from whatever walk of life. It could be abuse, neglect, or maltreatment. Now, what is some triggers that you might see? This is an important concept. What would you see in a child that is being abused, the family? Well, it could be due to poverty, lack of money, right? It could be parents' substance abuse. It could be that maybe they were abused as a child. So those are high risk areas for children that can be abused. There's emotional abuse. You're stupid, you're dumb, right? That makes you feel great. No, that's emotional abuse. Emotional neglect. You never say I love you, never hug you, and you crave for that as a child, for your parent to hug and love you. Sexual abuse can be from anybody. Could be the next door neighbor, to your uncle, to the cousin, or whoever. I've seen many different types of that. Physical neglect, they don't have food, they don't have shelter, they don't have clothes. And then physical abuse, where the child has injuries. So, what is your job as a nurse? Well, number one, if you suspect it, if you're in a hospital, you're suspecting it, you go to the charge nurse, you go to the physician and tell them what you think. And what they do is they will call out the proper agencies to check it. And you're like, well, what if it wasn't? I'm going to feel bad. Well, what if it was and you didn't? So your job as nurses is to protect children. I have seen 3 cases and really bad abuse type things that I did say, I think this is what it is. And they did call the police in, they did call DCF, and they were all real things. And I just hope there was never a kid who went through me that didn't get their proper care and are protected. How do you check for child abuse? Well, we know if the injuries don't match what they're telling you, something's wrong. Or if you see things like bruising, in different places that you don't know about. You can look at younger kids. Are they dirty? Don't always say that they're dirty, because kids go out and play in the mud and then get hurt. That's a different thing, okay? But assess that child, see what's going on. Now, there's a way to look at bruises and say, when did it happen? And here we are. 1 to 2 days, it's swollen and tender. 0 to 5, red or purple. 5 to 7, this bruise is now green, then it turns yellow and brown. So when they tell you it happened yesterday and it's yellow and green, it happened a week ago. It's not matching the story. Cultural and medical issues. Remember, there is really important that some cultural practices that might be considered abuse to realize they're not. And the one that comes to mind to me is like when they do this cupping, the Oriental groups where they cup and it's like this, they put heat and put it on the back to relieve pain, and it leaves these little round circles of bruising. That's not abuse. They're just trying to help themselves. So again, make sure that you know culture, or ask. Many parents, they're not abusing. They're going to tell you what that's all about. So a mother gets a call from a 12-year-old daughter's school nurse. The nurse informs her that their daughter has scoliosis, which was detected during a routine school testing. The mother has never heard of scoliosis and is concerned that her daughter will be crippled for life. What should the school nurse tell her? How do we treat scoliosis? 20 to 40% curvature. Well, we know that is going to be, they're going to do just physical therapy, put them in a brace, right? And that brace is on 23 hours a day. And the exercises, my daughter's best friend had scoliosis, and that's what she did. She did the brace, and she's got a great spine now. Any questions? Anybody have questions? Have I put you to sleep yet? No, okay. Let's go ahead, let's do the cahoots, okay?
Yes, Professor. Excuse me, I was trying to say something.
Sure.
With regards to the Friday class that will be missing for the Thanksgiving, I was wondering if you could make an arrangement with the other professor that will be having Tuesday class. It's optional. Whosoever wants to attend the Tuesday class, they attend. I don't know.
You are absolutely welcome to attend another class. They have Monday and Tuesday classes. You are
Okay.
absolutely welcome. I will send you a recording.
Okay. A recording of the
Okay?
class or the code. I don't know. What are you going to send me?
I can send you the classes if you want to attend with the Zooms. And I also will be sending you a recording that I have done.
Oh, okay, okay. Well, see, if you have a recording, that's good. Okay.
And the
Okay,
other
thank you.
thing is that quiz that's supposed to be that week, we're going to do on week 10.
Week 10, yeah, I
So
know
you
you
don't
said
have
that
to
one.
worry about that one, okay?
Okay, I know, yes. Okay. Well, since you have a recording, I think that's okay. Okay, thank you.
No, you're welcome. Good question. Appreciate it. Gives good clarity. Now, this is a good cahoots. It's a lot of concepts that you're going to see on your exam, so pay attention. The nurse explains that Brian traction is reserved for children who weigh less than blank pounds. So a lot of these concepts you're going to see on the exam. So this is actually one of those good things to go back and review. I've also sent you week 4 and 5 concepts that were also attached to your announcements. So Brian's traction is where the one that goes feet up in the air. The kid can't be more than 30 pounds. It won't work. What intervention will a nurse caring for a child with buckskin traction implement? Buck's traction is when they lay down, that whole leg is pulled and it goes up into a traction. Usually it's to pull that fractured femur so the bones are not out there irritating the muscles. It keeps it straight. So this is a child that if they don't have that trapeze because of the type of injury, you need to help them up in the bed. It's very painful. That muscle and those little bone chips can really hurt. What pain management would be the most appropriate for a child with a fractured femur repair? When you have a fractured femur, it hurts. It's swollen. All of the nerves have been damaged in the muscles. You're going to need opioids. This would be a good one for morphine, okay? Ibuprofen is not enough for any age child with a fractured femur, okay? What will the nurse include when caring for a child in Buck's extension traction? So remember, we've got the skin traction on pulling, and sometimes it can irritate. Remember, I said to check, make sure there's no breakdowns that are going on. Always check skin. Make sure the integrity of your skin is good. Making sure that the weights are the way that they should, right? Very important things with bucks. What is included in the definition of pain according to the Academy of Pediatrics? What is the definition of pain? You know, this is a definition that actually changed in the last several years. And pain is whatever they say it is. We can't argue with it. We used to say, well, you don't have pain. You don't look like it. You can't do that anymore. The pain is whatever the client says it is. Whatever it says it does, that is pain. What statement by the mother indicates understanding how to administer oral antibiotics for otitis media? So, with any antibiotics, they need to finish it all. So, this mother knows better. You don't, until the symptoms go away, you don't share it. And, some parents have to because they can't afford the 2 doses. But the thing that should be is administer all of them until all the medicine is used. A multi. What is the best way for the nurse to communicate with a 10-year-old child who has a hearing impairment? They can't hear. It's all of the above. It was one of the slides on the PowerPoint. Face to face, eye level, eye contact, short sentences, and don't over exaggerate the words that you're trying to say. What is the best way for the nurse to communicate with a child age 10 who has a hearing impairment? Just another way of saying the same thing, isn't it? So again, looking at them face to face and clear, short sentences, not over exaggerated. Very good. The nurse is reviewing the characteristics of Ewing sarcoma, which statement indicates understanding of this disease. Well, what is Ewing sarcoma? It's a cancer of a bone. I've seen it in the jaw, the scapula, the different bones in the body, but those are the two different ones. Like you see it big in the back, big in the jaw. Now, what they do is they do radiation and chemo. If they can, they'll remove it. If they can't, like a jaw or scapula, that will help decrease it. And many times it's all they have to do. What characteristic manifestation does a nurse caring for a child with Duchenne muscular dystrophy document? Remember, boys, ages 3 to 5, is 2 to 5, is when they just start seeing these things, the characteristics of it. And they're starting to fall. They are starting to have not atrophy, but their calves get big, hypertrophy, and they're going to be delayed, but more gross motor than you're fine. The nurse is providing instructions about how to treat a sprained ankle, a statement that needs additional treatment. Which one there's not right? Sprained ankle, what do you do? Well, we're not going to put heat on it. Like, why wouldn't you put heat on a sprained ankle? There's ripping, there's tearing, and capillaries are broken. So it swells in there. That's why it gets bruised, ecchymotic, and swells. Put on there warm, you are increasing the size of these vessels and increasing the swelling and make it hurt more. You're going to put an ACE bandage on it. They're going to elevate it, and you're going to put ice on it. Rice. Rest, ice, contain, elevate. How is pain managed the most effective way? Let's say you have a fractured femur. You know, when you have pain, how are you going to manage that best possible way you can? The best way is to give the lowest dose you can, but around the clock. Don't miss a dose. And when you're consistent, it's better than just giving periodic big doses. It just works more effectively. How does Russell's traction provide adequate skin traction? Remember Russell's traction? Similar to Buck's traction, but what does it do? It has that extra attraction that pulls it from two places. And that helps actually with better traction for some children. What finding would the nurse assessing the neurovascular signs of a child in Russell's traction report immediately? That's that double traction thing there. Well, anything that has to do with prolonged neurovascular signs, blood's not getting where it should be, there's a problem. So bluish discoloration, absolutely you're going to report that. What intervention is appropriate for a nurse assessing a pre-adolescent child for scoliosis? What do you see? Got a curvature of that spine. So if you bend them forward, you're going to see the back crooked. You're going to see a shoulder taller than the other, and one arm is going to appear longer than the other. That's what you see with scoliosis. What nursing action will significantly decrease the risk of serious complications for a child in Bryant traction? I mean, what are you most concerned about? What are you checking? What's part of your assessment? Neurovascular signs. As simple as checking neurovascular signs frequently is going to help you prevent bad complications on your child. Which intervention would be helpful in relieving morning discomfort associated with juvenile rheumatoid arthritis, or JIA? So remember with JIA, because they've been laying all night, they're going to be stiff, right? It's just part of those joints. So if before we got up, we did some moist heat on it, it's going to make it easier to move. Now, putting splints on means you're not moving. What you've done is made it worse because movement is what keeps those joints moving and decreases pain. Okay? What instruction would the nurse provide to an adolescent who's been fitted with a Milwaukee brace? That is what we use for scoliosis. Treatment for scoliosis is your brace. This name is Milwaukee brace. So care of that brace. You're going to put a t-shirt on, and it's like plastic like. Then put the brace over. You're only allowed to take it off for 1 hour a day, and that's to bathe. You wear it to bed at night and leave it there while you're exercising also. So if you put it over a t-shirt, it helps with that friction and the rubbing, etc. What observation makes the nurse consider the possibility of child abuse when a mother says her young child fell down? So the bruises are significant of a week ago. They're not today. So we know that is a problem, right? So knowing the color of bruises can help you uh, take care of a child. On entering the room of a child in Buck's traction, what observation requires a nursing intervention? For Buck's traction, skin traction, pulling the leg with a pulley over into, your weight. What is not what you want to see? Well, there's no pull going on if the heels are at the end of the bed. There's no pull. You have to put that foot away from the foot of bed so it is pulling correctly. Very good. You knew that one. What type of fracture would be the most likely to alert the nurse to the possibility of physical abuse? And that's the spiral. It cracks. It's like they took them and they arm it like that. And it's usually your radial and your ulnar bones that do it. The spiral fracture is related to abuse. A multi. What factor may trigger abuse in a parent? What would make a child abuse a parent abuse a child? What factors? Substance abuse, just overwhelmed, they were abused, financial issues. Those are things, not a high self-esteem and not a knowledge deficit. I mean, parents don't know what they're doing. We're playing it as we go along because there's not really a book, even myself. But the other ones definitely. That's a question you need to remember. What assessment made by the school nurse would lead to the suspicion of strabismus? What is strabismus? You have amblyopia, strabismus, and nystagmus. What is it? And these are all eye problems. So what you need to do is you cover one eye because both of them can't work together. So they use one eye to look. And that's exactly what they would do. Very good. What might the nurse explain is a common treatment for amblyopia? So amblyopia is a lazy eye. So you want the muscle to work. So you cover the good eye and make that bad eye muscle work. Patch the good eye. And they do it periodically during the day. What assessment does the school nurse recognize as a cardinal sign of hypema? And remember, that's increase in bleeding. So that's a dark red spot, and you would see it in the eye. What type of fracture is an incomplete fracture where one side of the bone is bent and the other side is broken? And it's called green stick. Very good. What does the nurse explain to parents of a child with febrile seizures? Well, febrile seizures are a seizure from a fever, but it's not that they have a fever high. It's one that goes from 0 to fever quickly, and that sparks the brain, and that's when they have the seizure. What type of fracture is associated with child abuse? You didn't know it before, you know it now. And that's a spiral. Very good. A multi. What factors may trigger a parent to abuse their child? You had the one before that had 8 of them. Which one's here? And again, it's all of them. Finances, they were abused, drug abuse, financial unemployment. Yes. Child experiences episodes where he appears to be staring into space. What type of seizure is that? And that's what we call absent. I don't know what a myoclonic is, something muscle, but absent means just you're looking. What is an appropriate nursing action when a child has experienced a generalized tonic-clonic seizure? So at this point, it's all about protecting them. So getting things out of the area that can hurt them, turn them on their side in case they vomit, but you don't assist anything, you don't leave them, you never restrain, and nothing ever inside the mouth. It won't work. The legs of a child with CP cross involuntarily and exhibits jerky movements with his arms. What type of cerebral palsy is this called? And it's the positioning here that is a type of cerebral palsy. And it's called spastic. And this was my little Jonathan. He couldn't control himself, but that is what we saw with him, even with all of the treatment he got, botulism and all that. What assessment finding in a child with meningitis should be reported immediately? This is a difficult question. Like, which one is the most high alert here? The blood pressure. Because remember, drop in blood pressure decreases blood flow to the brain. Now you're worried about brain injury, hypoxemia, right? Which could cause more problems. Blood pressure, yes. What nursing assessment suggests the child has a concussion after a child fell and hit the head on the ground? What's one of the biggest things you see with the children who's hit their head? A concussion. And it's that amnesia. They don't remember. That's telling you that definitely that's a concussion. And last question. A 6-month-old child gets inoculated with Haemophilus influenza type B. What does this immunization protect against? Think about it. And it's influenza, as simple as that. Let's see how we did today. Number 3, Ryan. Good job, Ryan. Number 2, Char. Thanks, Charlie. Good job. Number 1, Millie. Good job, guys. Number 4, KK and Mimi. All right, guys, the end of today. Thank you for another great class. Remember, next week is your exam. Please come for the exam on your phones, and then we will go into on the computers. If you need any help or extra help, just let me know, and I'll be here for you, okay? Have a great evening.